Okay, welcome to the final session, the roundtable discussion on continuous topical oxygen therapy. And I want to thank you all for hanging on and being a part of this awesome event. It's been very, very educational so far. I think a lot of questions, a lot of interaction. So I'm just going to jump right into it. Let's go with this for a start. So when considering continuous topical oxygen therapy versus intermittent oxygen therapy, what factors should clinicians consider in deciding which approach to use for their patients? And any one of you can jump in on that one. Don't all jump in at one time.
I think Wendy should take this one.
Yeah, I do too.
Okay.
Well, I think that it stands to reason that continuous topical oxygen therapy has benefits over intermittent topical oxygen therapy. First off, with continuous topical oxygen therapy, and we mentioned it, and several of us mentioned it, and I did as well during the talk, is it's a mobile device, so it's wearable. The patient continues to be able to go about their activities of daily living, and that constant oxygen deficit, which we all brought up within our presentation, it is being managed, right? With intermittent therapy, unfortunately, it's something that the patient has to stop their activities. They have to hook up to a device. They have to sit still for 90 minutes. They have to be compliant. We have to rely on the patient to do that. And it's only giving that burst, not that continuous oxygen that we know that there is that need. And even in Dr. Wahhab's presentation, where she shows the physiologic need for more oxygen in the tissues, is not just, it doesn't stop even after the wound heals. So I think it's more effective in that regard, and it supports the patient's lifestyle better.
Mm-hmm. Okay, well, we got a couple questions that just popped in. So we got Dr. Blythe. How do we find out more information about incorporating it into their clinic? And my recommendation would be to get with somebody from the NATROX team, or Tom, do you have anything you want to add to that?
No. Again, that's that the NATROX teams here are available. And I think that they're very good at what they do, but that's not really what I do well.
Yours, yeah. Well, we'll put you in touch with the NATROX team. As a matter of fact, you could go right into the exhibit hall, click on their booth, and send them a message, Joanne, and then they'll get back to you and answer any of those questions specific to incorporating into the clinic. Dr. Faust, at what point do you apply topical oxygen therapy? Do you consider it first-line treatment or recommend second after 4 weeks?
Naz, you want to take this, since you're the one who was doing the case studies?
Yeah, I'll take this. I mean, I honestly think that clinically, as a clinician for over 21 years, I want to use this first line. These patients who are coming to a wound center or clinic, they're chronic regardless, and they're non-healing. They're the hardest to heal wounds. So to be honest, those are the people that really need it quickly to actually be able to close these people quickly and to stop all the comorbid secondary effects. So clinically, I would like that. Whether your LCD will approve of that or not, is a whole nother situation. But you saw in my cases that I used it on patient just post 1 week of presentation, and also post 22 weeks. And so I guess at this point, just use it because, it's probably going to help.
She also followed up with a lot of discussion regarding ulcers and
Pressure injuries, I think.
Leg ulcers. What experience do you have with pressure injuries?
Hi, Liz. I'll take this one. So we have some cases, and we're looking at an expanded case series in pressure injuries. I don't have to tell you, Liz, or anybody who's joining us, that boy, it's a hard patient cohort to study, right? And to do RCTs or any, cohort studies, there's so many variables, place of service, comorbidities, reasons why patients have pressure injuries, controlling nutrition, make sure our patients are being compliant with offloading. I can go on and on and on and on and on. So, that's why there's no gold standard for pressure injuries except for removing the pressure. But we're looking into it. So stay tuned. That's something we're very interested in studying. And we do have a trial, a project currently to get some more data on that.
She also had another one. Can you make a direct link to topical oxygen therapy and reduction of biofilm or just bacterial load?
I'll just tell you, clinically, we could absolutely see that there was a movement of the bacteria, coming out. The exudate was increased. There was a ton, some that were colonized with Pseudomonas. Actually, a lot more green exudate would come out. So it's definitely clinically there is something happening. So,
is it recommended to use NATROX on burns, especially any large ones? Tom?
So we have used it on small second-degree burns, but there's no evidence on the large burns. I don't see why it wouldn't. I mean, the wheel is kind of small. It would be hard to use. You'd have to use a lot of units to use it on a large burn. But, if you look at the natural progression of devices and products from chronic, hard-to-heal wounds, burns are they're a natural extension. In fact, if you look at the burn meetings, more and more of us wound doctors have gone in and are attending the burn meetings because the healing process and challenges are similar.
Mm-hmm. Are there any contraindications? That was one of the questions that came up in one of the other sessions that you know of. Are there any that you know of? Any of you could speak to that.
I can take that. Yeah. So there are a few, we wouldn't want to use this on an actively infected wound without treating the infection, right? Same with osteomyelitis. So osteomyelitis, untreated osteomyelitis would be a contraindication. Any wounds that have deep sinus tracts or fistulas that you can't probe to the end to, it would be contraindicated to use topical oxygen therapy. Wounds that we think might have underlying cancer would also be a contraindication as well. And there's some other disease states that are contraindications. Believe it or not, Raynaud's and some of the micro vessel disease. And even though that's counterintuitive, topical oxygen therapy was a 510K product. The initial product, the FDA clearance and the contraindications were sort of grandfathered to us. And so you can find the full list in the IFU as well. But those are some of the most common contraindications.
Okay. There was also another question. What about using it under compression?
Absolutely.
Okay.
We use it with offloading, like Tom had mentioned, the RCT. We used it with total contact casts with no problems under compression bandages as well. So it can be used with most standard of care dressings. You just want to apply a semi-permeable dressing over top of the oxygen delivery system. So you kind of control or hold in some of the oxygen. But other than that, you could use any other secondary dressing, compression, offloading of your choice.
Good. And then we have can we use it on radiated wounds?
Yes. So that in my case study that we talked about during the presentation was a patient that had Mohs surgery and then radiation and had radiation tissue necrosis and a chronic stalled wound of the leg. And so we had successful therapy, and we just had a publication of a 3-patient case series where we used it on patients having Mohs surgery, having radiation, having the ill effects of radiation tissue necrosis, subsequently non-healing wounds, and we had really good results. So that just published in Wounds the end of December.
Mm-hmm. And explain that the consensus document in like the one in JWC. Like, we should be taking note of this when it's covered on that level. And do you think that it is as that it's as big as we see it be? See it at this point, given the fact that it came out in that journal. What do you think about that?
Well, we do a lot of consensus documents. I think that what really separates this one from many consensus documents is that it's really based on a tremendous amount of evidence. I mean, all the meta-analysis, all of the clinical trials, all the case series. Topical oxygen has a really good evidence base. And the nice thing about consensus documents is they take all the information, they put it one place. So you can look in one place and, learn, what Greg's doing on the animal models and in the lab, and what Naz is doing and Wind you're doing on the case series. So it really is a sort of the full spectrum. That's why I like it. I mean, that's why I keep a copy of it.
Well, for sure. As we've been discussed, it's just like the biggest thing coming right now in terms of treatment. We have this. We're going to go with this one, Greg. How does continuous topical oxygen therapy support the fight against the infection in wounds?
One of the most important aspects is that it increases the ability of our immune cells, neutrophils, and macrophages to effectively produce the reactive oxygen species and reactive nitrogen species. And as the data I showed, if there's a reduction in the availability of oxygen in the wound, then the neutrophils and macrophages are tremendously impaired in terms of generating the microbicidal reactive oxygen molecules, the hydrogen peroxide and the hypochlorous acid. So in large part, the effect is directly on the neutrophils and macrophages. And then finally, also just by activating a lot of the metabolically dormant bacteria that can be single cells, but are typically more common and frequent in the mature biofilms. And again, that increases the sensitivity to the antibiotics that are used, and even to some of the antiseptics.
Dr. Wahab, do you see any changes such as reduced antibiotic use in patients following continuous oxygen therapy?
Yeah, I mean, anecdotally, I'll tell you on some of these patients that I had been treating for 12 weeks plus prior to the application of continuous oxygen, they were on antibiotics, and it just reverted back, and it reverted back to the same chronicity of that wound. We started to apply the topical oxygen, and some of them we actually treated with oral antibiotics because I did get a culture post application, and there was definitely a positive culture there. And so I do see that where Dr. Schultz was talking about the synergistic effect of how antibiotics are utilized and can be actually, kind of on steroids with the oxygen, it actually helps much more. And it actually decreased the amount of time we needed to use the antibiotics significantly, or we didn't need to use them at all because it was a natural mechanism that was happening.
Yeah, so they don't have to deal with the antibiotic resistance.
Yeah.
Dr. Cole, how quickly do the patients feel the impact of this reduced pain? Is it immediate, or what's your assessment on that?
Yeah, so we first started to see this during the RCT. And again, we were looking at diabetic foot ulcers and neuropathic patients, but they still have wound pain. I still want to make that point. Even though they're neuropathic, they still get neuritis and neuropathy, those burning, tingling sensations. And we were just hearing it anecdotally, within like a week or two of application, where patients are like, my neuropathy pain is less. And then we started using it clinically and in different wound etiologies, same thing, especially those very painful venous leg ulcers and even, trauma injuries. And that was a repeated theme through the patients saying, hey, this was really keeping me up at night. And now we're using topical oxygen and we see the pain lessen. It is fairly soon after start. And I think, Naz, in your case series, you also had experienced that as well, correct?
Yeah, absolutely. I mean, there was definitely people, and in fact, more than the patient, the actual spouses of the patients were so appreciative and thankful. I mean, it was just they were volunteering their testimonials just to be able to say how much better it made their life at home, you know, in general.
We have a question from Tia. Do you use wound dressings, and when and in what phase? And well, we're not going to go into specifics on which wound dressing, but do you use wound dressings with the
Topical oxygen? Yeah.
oxygen? Yes.
Yeah. So the topical oxygen device, the oxygen generator, the oxygen delivery system, will go directly on the wound, but then you need to apply a secondary dressing for exudate management to keep the oxygen delivery system on the wound. So what's wonderful is you could use whatever dressing you feel is appropriate, whatever dressings you have at your facilities and that you routinely use. It's just like regular practice. You use the dressing dependent on the exudate, right? So initially, as Dr. Wahab mentioned, you see a lot of exudate coming from the wounds when we start using topical oxygen, which makes sense, right? We're turning on a light switch, so to speak. We're stimulating the wound environment. A lot of processes are going on, as Dr. Schultz had really alluded to in his presentation. So exudate, it tends to be larger or increased in those first couple weeks. So you might want to use a super absorber or something like that. Then you could back down to a foam or an alginate, but really you could use whatever you currently use, but as long as it's semi-permeable, again, to try to maintain that oxygen gradient in around the wound tissues. And then you, for this particular device, the oxygen delivery system is changed every time you change the dressing.
Okay. Dr. Serena, what are your thoughts on the improved durability seen with wounds treated with continuous topical oxygen therapy?
Well, I think the evidence for durability is pretty clear. As Wendy said earlier, we'd love to go back and biopsy and look at the collagen, but no one's going to let us do that. But we saw it in this study, and we saw it in other studies. Right now, we're working on putting all the long-term follow-ups together to see if we can get something with some bigger numbers in it. But I think you at least in diabetic ulcers, you see a more durable closure. And that really goes to Greg's point of you get better collagen when there's more oxygen around.
Mm-hmm. Why? This goes to Greg or Dr. Schultz. Why is the oxygen needed for so many critical processes in wound healing? Like I think we talk about it, but I think it's important to just go a little bit further in depth on why is it so necessary? Why have we seen it so necessary?
Well, it comes back to the fact that our whole evolution is based on the use of oxygen to generate energy, and then everything else sort of follows from that generation of energy. And so we have to exist from the smallest microbes up to us, typically in an oxygen-rich environment. And so oxygen has evolved to play these key roles because of the fundamental aspects that oxygen evolved to produce. And that's everything from energy to antimicrobial molecules to stabilizing things with enzymes. So, we evolved to be able to take advantage of an oxygen-rich environment because it allowed the organisms in us to do many more things more rapidly and better. So, we didn't evolve in an anaerobic world. We evolved in an aerobic world.
Mm-hmm. Yeah. I think we well, anyway, let's get to the next one. This is interesting. Can we use a NATROX on ischemic nipple due to mastectomy and implant-based reconstruction?
So, there are a number of case studies that have been presented, not quite published yet, that where plastic surgeons have used it on cyanotic nipples after reconstruction and on some cyanotic flaps. So I guess the answer to can is yes, you can. It's obviously off label. This is CME, so we have to say that. Mm-hmm. But I can tell you that there are individuals that are reporting on it.
Awesome.
Maybe I could add one thing to that. Dr. Serena and I were at the Boswick burn meeting this previous week. And one thing that struck me at that meeting is that there are limited opportunities clinically to try and reduce the conversion of early burns in some areas into more severe burns or even full thickness burns. And so I think that's something that needs to be looked at in a lot more detail, because in many of the cases that were presented there, the burn surgeons would say, we're waiting 2 or 3 days to watch the progression of these burns to stabilize, and they go from, simple second degrees to deeper second degrees to third degrees. And I'm sitting there thinking to myself, when they see these areas that are at high risk of progression to full thickness third degree burns, that could be a really nice opportunity to put up one of the NATROX dressings over there to try to prevent that progression in these at-risk areas into full third degree burns. And the other thing, and maybe Tom can comment on this too, is that I was so impressed with the number of clinics and clinicians that are using the skin cell mincing spray-on treatments to fill in with the fenestrations within autologous split thickness skin grafts, or even with the extracellular matrix surrogates that are being put onto wounds to build granulation tissue and then seeding that with the autologous skin cells. And I'm thinking to myself, this is another area that needs to be looked at very carefully, because I think particularly in areas where there is poor perfusion to begin with, first of all, developing the granulation tissue is weak, but then the stem cells that are being sprayed from the autologous skin preps need to have as much oxygen as they can to rapidly attach, proliferate, divide, and cover those wounds. So I don't know, Tom, did you did that strike you with how many people are now using the skin cell sprays and treatments?
Yeah, it's interesting because we did a large trial on epidermal grafting in venous leg ulcers, and if you can get the grafts to survive, you get venous leg ulcer healing in 3 or 4 weeks, and there's a number of reasons why they don't. High levels of bacteria, but adding something like topical oxygen makes a lot of sense to help these grafts survive, and particularly hard to heal wounds. We tend to use skin grafts in traumatic wounds and hard to heal wounds. We're looking at these other modalities, where low donor site morbidity modalities. And yeah, that does make a lot of sense. Also, just that whole preventing conversion in the burn world.
Right.
So it was a great idea. I had to write that
down. So we got another question. Do you ever combine this with negative pressure wound therapy?
I can take that one. Not simultaneously. Negative pressure wound therapy is causing granulation tissue formation, right? You're putting the foam down and if you put topical oxygen in there, you could run the risk of the oxygen delivery system becoming embedded in that new granulation tissue. And subsequently, there could be some adverse events that would occur. But I feel like there is, and Dr. Wahab had mentioned this during her presentation, the need for algorithmic care, right? So the indications and utilization for negative pressure are, to fill in wounds that have significant loss of tissue, or if there's a sinus tract or something of that nature, or to control exudate. Once you've reached the goal of therapy with negative pressure, it would stand to reason that you can then switch the patient for topical oxygen therapy to aid in epithelialization, because you're never going to get to epithelialization with negative wound therapy, because the negative pressure, the foam is always going to be in the wound, right? So it's a subsequent or step down sort of algorithm of care that we've been tinkering around with and looking to develop some cases around that.
Awesome. We had another question from let's see. Oh, from Tia. You said dressings, like when you use it in conjunction with dressings. Does that also include ones that have silver or carbon?
I think Greg should answer that. I mean, yes, to carbon, because carbon controls odor. So there's no problem with a secondary dressing that has carbon for odor control. But I'd like to hear, the silver from Greg.
Yeah, and that's actually an important point and question, because many times there are contraindications when people will say don't use this particular product with a silver dressing or whatever. In this case, it actually turns out, we haven't done the final experiments, but I can almost guarantee you from a chemical perspective, combining topical oxygen with an ionic silver or with the nanocrystalline silver, the Acticoat dressing, would actually enhance the antimicrobial activity, because the AG 0 plus or plus 1 can be superoxidized up to AG plus 3, which is even more microbicidal because it has a higher oxidation reduction potential. So I don't see any downside, in other words, any inactivation of the antimicrobial activity of ionic silver. Probably it would increase the percentage of higher oxidation states of the silver ion, which means it's going to kill a little bit better. The only downside of that might be it might reduce the amount of AG0, which is very anti-inflammatory, but that's only produced by the Acticoat dressing. All ionic silver dressings don't contain AG0.
Greg, I have a question about that. Would that increase cytotoxicity to, the good cells? Is that a possibility there?
Yes, it is, because the oxidation reactions of silver are not specific for bacteria. I mean, they kill bacteria really well. We tend to have higher tolerance to oxidizing silver than bacteria do, because we make reducing agents that normally, things like glutathiones and others, that keep our natural oxidative species, hydroperoxide and hypochlorous acid, from killing us, but bacteria don't make nearly as effective reducing agents, so they get killed by our reactive oxygen species much better and much more sensitive than what our cells are. But when you take silver and you oxidize it up, it doesn't really, it can't differentiate between bacteria very well or our human cells. It's just that our human cells are more tolerant to the oxidation of silver or reactive oxygens, because we make reducing molecules specifically to protect ourselves from all these super oxidizing agents. I mean, our mitochondria make them all the time. So it's not like we did it to make silver dressings better, right? We evolved that capacity because our mitochondria generate so much reactive oxygen species as a byproduct of generating ATP that we had to evolve the ability to protect ourselves against our own reactive oxygen species.
Awesome.
Probably more biochemistry than you ever wanted to hear about that.
Well, I'm just going to give each of you a quick opportunity to say, anything, any takeaway messages that you want to leave with the audience that's still here. My thank you to all of you for your participation. And once again, thank you to NATROX for their support of this event. I think it's been extremely informative, very educational, and I think there's been a lot of shared content that there's a lot of takeaways. But I was just wondering, I'll just go around the horn. We'll start with you, Wendy.
No, I just want to reiterate what you just said. Thank you. Thank you for everyone giving up your Saturday to spend with us to learn some pearls on topical oxygen therapy. We all took a little bit of a different look at the therapy. So I love when you can collaborate with a great group of people like this, and the questions were excellent. So thank you so much for the questions, because I think that's the best part of doing something like this, is hearing from the audience and understanding how people would use it or what their thoughts on a product is. So thank you all.
Absolutely. Dr. Wahab?
Yeah, thank you, for the opportunity as well. I think it's great. This type of therapy is, I think, just so underrated, and we really need a lot more fanfare behind it in order to get Medicare and other, people behind it to support it. There's a lot of clinical as well as, bench research behind it. It's just so needed. So those of you out there that are, part of that world, I would love for you guys to help us take the technology off to have it greater available to our patients.
Awesome. Tom?
There we go. So yes, I want to reiterate what Wendy and Nas said. We're very happy that you decided to spend your Saturday with us. It's always sunny and 70 on the web. So I hope you enjoyed it. It's certainly an area of very active research, and I'll put my own plug in. If you're interested in getting involved in with us in studying this, that's something you thought you always wanted to do, feel free to get a hold of myself or Dr. Cole, and we can get you involved in some of the clinical research activities that are ongoing.
Greg?
Just add that I learned so much from the clinical presentations, so that was really helpful for me. And I think this is a technology that we haven't really had access to efficiently until now. And I think you're going to see the applications of the continuous topical oxygen therapy move into multiple different areas. And we saw several of those questions that were kind of leading us to think about, well, maybe this could be useful in these other areas. So I think we're really just seeing the start of something other than, oh, we're going to treat an ischemic chronic wound. I think we're going to start seeing this used very effectively in stimulating healing in multiple kinds of other wounds.
Absolutely. Once again, thank you all so much. Really appreciated the morning and into the early afternoon. Enjoy the rest of your weekend, and we'll be in touch soon.
Excellent.
Thank you.
Take care.
Bye.
Bye.